Hello and welcome to this episode of the Optometric Insights podcast, where we're talking to Julie Rodman about OCTA and how it helps us in clinical practice on a daily basis. So, Julie, thank you for joining us again. We're going to be doing a deep dive into OCT and geography, but tell me first and foremost, kind of what it's done to your practice and just some of the highlights around OCTA and what it's really done from how you're managing patients at this point moving forward.
First of all, thank you for the invite. It's always fun to be with you. Um, I would say that OCTA has definitely revolutionized the way that I have practiced, and I think most of us would say that. We all are accustomed to using OCT and getting great structural slash anatomical information about a patient's retina. But what we've lacked is the ability to really visualize function, the ability to visualize blood flow. And really to visualize some of these abnormalities that don't sometimes do a great job on OCT. So this has provided an outlet for optometrists to, I don't know if the outlet's the right word, but a way for us to see things that we used to have to refer for fluorescein angiography. And everyone knows that OCTA is non-invasive, it's safe, we can do it multiple times on the same patient without, any issues. So I feel like it certainly made me a better diagnostician. I can't imagine not practicing with it anymore. There's many days when I need to go to the machine to really, solidify something that I think I see clinically. So that's where it's fit into my practice.
It is interesting, and it's actually become standard care at this point. Unfortunately, CMS has given us a code that's now representative of the additional time and expertise that's required to interpret these scans as well, too, which is excellent. And also a little bit more technician time because, again, these scans are more data rich and robust as well, too, because there's so much information that they're getting. It's interesting how the system's literally taking scans milliseconds after each other and comparing them and recreating the blood vessel or the vascular supply. We're actually looking at some anterior segment applications as well too, especially with scleral lenses, which is going to be a topic for another discussion. But Julie, when we talk about the genericity of these technologies, oftentimes that kind of gets washed out. And it's really the cases and the patients that it's made a difference that are important for us. Julie, give us an example of a case where OCTA really kind of stepped up to the plate and helped you be a better diagnostician, and also as well to how it changed the management for the patient that you cared for.
So not so recently, but a couple years back, I had a 40-ish-year-old gentleman who came in with what looked clinically like bilateral macular holes. And it was very strange because, as we know, someone in their 40s certainly shouldn't be presenting with
Yeah. So
any.
Julie, did it look like that on the fundus imaging or the posterior pole evaluation or both?
Yeah, so with 90, and then we also took some fundus images, and it certainly looked like the patient had macular holes. So I said to the student, I'm like, let's go get OCT. Of course, that's what I always do whenever I'm, second guessing my diagnosis.
Yeah.
It just didn't make sense.
And I'm assuming too the patient had a reduced best corrected visual acuity as well
I
too.
did. If I remember,
Okay.
I think he was around 2030 or 2040. And,
Okay.
really, he was not a high myope. There just was nothing wrong with him. He wasn't diabetic. There
Yeah.
was really no reason to substantiate why this would happen. So, anyway,
Yeah.
we get OCT, and the OCT did give us some excellent information, but the OCTA really drove the point home. So, what we ended up finding was on the OCT, we found something called an ILM drape. And an ILM drape is really a word that's pathognomonic for macular telangiectasia. So, I could walk through what happens in MACTEL, but really what happens is it begins in the sensory retina. The abnormalities form cavitations in the sensory retina. Later, it affects the outer retina. And if the cystic cavitations fuse, you can actually get what looks like a macular hole formation. So not a true macular, well, it is, I mean, it is a macular hole, but not a macular hole from vitreoretinal disease or vitreomacular interface disease. This is more of a neurodegenerative disease that causes something that could possibly look like a macular hole. So then I said, okay, fabulous. We identified these things on OCT. We saw the structural changes, but what's happening at the vascular level? And when you do OCTA, really this disease happens because there is an abnormal blood flow. There's abnormal really temporal perifoveal vasculature. And you can visualize that on the OCTA. You can actually see the anomalous vasculature on OCTA, and it gives you this, again, pathognomonic appearance. So maybe somebody wasn't sure just on OCT, what am I seeing here? Why am I seeing cystic spaces? Why am I seeing what looks like a macular hole? And then you go and you do OCTA, and the OCTA really identifies that this is a vascular abnormality.
So, Julie, the beauty of the OCTA is that we can get different cuts of different sections of the retina. We can get the very inner portions of the retina. We can get that middle bundle of the retina. We can get the outer segment of the retina. And we can also go into the choriocapillaris as well, too. Give us highlights on, I mean, where you're looking for MAC telangiectasia. Where and what cuts are you looking at those scans in at the with the OCTA?
Yes, that's a great point. Macular telangiectasia is actually a disease that originates in the deep plexus of the sensory retina. So it's somewhere in between, the top and the bottom of the retinal scan. So when you're looking at OCTA, the area or the slab of interest, at least initially, is going to be that deep plexus. The deep plexus is somewhere around, let's say, OPL and towards the photoreceptors. But
Uh-huh.
then it actually goes high to the superficial plexus and then goes back down towards the photoreceptors and beneath that. So it's interesting. It's a great point because understanding which slab to look at is going to help to identify the pathology. It's almost like when you think about retinal angiomatous proliferation, which is a type 3 choroidal neovascular membrane. People don't recognize that this is actually a disease that originates in the deep plexus. It's not like a normal CNV. So on OCTA, looking specifically at that deep plexus is going to really help you to understand the pathophysiology. So yes, that's a great point, Melaine. A lot of people say to me, I don't want to get OCTA because it's hard to interpret. I'm afraid if I get it, I'm not going to be sure what I do. And I kind of go back and say to them, well, think about how you felt when you first got OCT, right? It's almost
Yeah.
reading an MRI.
Yeah.
And you become more comfortable the more you use it. So
Yep.
I would argue that it will give you better information than not having it. And then there's people that you can always ask for help. But that's not a reason not to adopt this great, cutting edge technology.
We've Julie been using it a lot as well too for diabetic patients, in particular those individuals who have a reduced best corrected visual acuity unexplained. Oftentimes these individuals have a lot of vascular dropout,
Yeah.
in particular in those superficial layers, without any signs of retinopathy, which is so peculiar and so bizarre, but it gives you a greater appreciation clinically about what's actually happening before we see retinopathy, the level of dropout that you see some at times before you see retinopathy. So you realize that even at mild levels of diabetic non-proliferative retinopathy, you have substantial changes in the vascular plexus that are occurring in the eye. And again, from a clinical perspective, it just helps you communicate differently to the PCPs that are caring for these individuals as well, too.
And Mila, that's a great point because that actually what you're describing is something called macular ischemia. And macular ischemia doesn't show up on regular OCT. It's one of those things that, a patient comes in, they're 20/50, 20/60. They don't have lenticular opacities to explain the vision. Their OCT looks perfect, and you're scratching your head and you're saying, I don't see diabetic retinopathy. I don't see anything in the media. So why is the vision decreased? Get OCTA and you see that the foveolae vascular zone is completely obliterated. There's so much
Mhm.
capillary non-perfusion. So that's actually, there's a term called macular ischemia. And the trouble with it is that it doesn't do well with anti-VEGF, right? So like you think about referring these patients, you say, oh, we're going to refer you, you'll be fine. It doesn't work that way. It's not like macular edema. So it has a very guarded prognosis. So if you didn't have OCTA and you had this kind of patient, I say to my friend, what would you do? Right? You'd have to refer it,
Mhm.
right? You'd have to refer it to figure out why this patient's vision's decreased. Why are they not pinholing to 20/20 when you can't find a pathology clinically?
Mm. Great stuff, Julie. As always, you're a whirlwind of information and knowledge, and your true unique combination of clinical and academia, both of those things just make you an absolute gem and a gift to the optometric
You're
profession. And we
great.
thank you for everything you do,
Thank you. Thank you for the invite. I look forward to seeing you again soon.
of course. And thank you all for joining us on this episode of the Optometric Insights Show.